How's it going, guys? We have a pass level question for pathology, step one. If you're studying for internal medicine, you should still know these values here. So we are handing you the light microscopy biopsy of small cell bronchogenic carcinoma. Histology overall, do you need to obsess about it for the pass fail step one? Absolutely not. But there are some findings that are mandatory as high yield that will show up, okay? You need to know that small cell bronchogenic carcinoma is going to be these tightly packed basophilic cells. Basophilic means purple, okay? Eosinophilic means pink. So you got all these basophilic cells here. You say, I don't know what I'm looking at. That's fine, but we clearly have a biopsy of a chest lesion and you got all these electrolyte findings. You should be thinking about paraneoplastic syndromes, and then you got all these basophilic cells. There can't be that many things this is referring to. So if you look at the answers, you know that small cell bronchogenic carcinoma, one of its paraneoplastics is SIADH, so it can cause SIADH, Cushing's due to ACTH, Lambert-Eaton due to antibodies against presynaptic voltage-gated calcium channels, can also cause a multitude of neurologic issues apart from Lambert-Eaton, such as cerebellar dysfunction, anti-Hu, anti-Yo antibodies. And then you've got calcium and phosphate related findings that are fucking wrong, because these would be squamous cell carcinoma of the lung, which the biopsy is completely disparate. It would be showing you pink circles, which are keratin or squamous pearls. Okay, so I've linked my pulmonary PDF below, don't worry, and just literally look at the images that I put in there that for the USMLE, very easy. So we are looking at small cell bronchogenic, and we, as I already said, we can eliminate D&E here because these would be for squamous cells secreting PTHRP. So we're looking for SIADH. Well, SIADH means too much ADH secretion, right? What does ADH do? It inserts aquaporins in the medullary collecting duct of the kidney, increasing free water absorption. So you're diluting out your serum. So your serum sodium, normally 135 to 145, so serum sodium's got to be low, so we're looking at A or B. And because we're pulling free water out of the urine's got to be concentrated. So we're looking at choice A as the correct answer. Not hard, okay? You say, I don't know the normal ranges. Well, you don't really need to if you conceptually understand what's going on. You clearly got some low values here, you got some higher values here. And so 135 to 145 normal for sodium. Urine specific gravity, very odd scale of 1.000, which is the most dilute possible, all the way up to 1.030, which is concentrated. So if we were to look at choice C, which is fucking wrong, this would be diabetes insipidus as an example, right? Because you either have insensitivity at the kidney, nephrogenic, or to ADH, or you have aposity, decreased ADH secretion. So you're not able to reabsorb free water and you get high serum sodium, dilute urine. So choice C would be for DI. Choice B would be for psychogenic polydipsia, where you can see your urine is dilute and your serum sodium is low. Okay, so choice A, our correct answer, SIADH. Choice B, psychogenic polydipsia, patients simply drinking too much. It's a psych disorder. And then choice C, as we said, is diabetes insipidus. And then if we are going to entertain, if it were squamous cell carcinoma of the lung, you would have high calcium, low phosphate. Okay, so calcium 8.4 to 10.2, and phosphorus 3 to 4.5. So this would be the answer if we had squamous cell carcinoma of the lung. It can also be renal cell carcinoma. It secretes PTHRP. I've talked about that as well, okay, in other YouTube clips. Choice E, wrong fucking answer. You know the deal. Until you make more content, like my subscription. Appreciate your time. That's it.